Morton's Neuroma. Contents: anatomy, description, etiology, mechanism of injury, symptoms, clinical examination, diagnostic procedure, conservative management, and finally, surgical management. Anatomy: the medial and lateral plantar nerve arise from the tibial nerve, providing sensory motor innervation to the sole of the foot. The common plantar digital nerves are branches of medial and lateral plantar nerve. The first, second, and third common plantar digital nerves usually arise from medial plantar nerve, while the fourth common plantar digital nerve usually arises from the lateral plantar nerve. The forefoot front part of the foot has 14 phalanges, toe bones, and 5 metatarsal bones that connect the forefoot to the midfoot. The areas between the bases of the metatarsal, known as whip spaces, are part of the forefoot. There are four whip spaces. The first whip space is located between the big toe and second toe. The second whip space is located between the second and the third toes. The third whip space is located between the third and the fourth toes. The fourth whip space is located between the fourth and the fifth toes. The nerves that give sensation to part of your toes are called the medial and lateral plantar nerve. These nerves travel along the bottom of your foot and branch out as they near the toes. The nerve branches in the forefoot at the level of the whip space are called common digital plantar nerves. In the whip space, the rounded ends of the metatarsal bones are connected to each other by ligaments called transverse metatarsal ligament. The common digital plantar tarsal nerve on the bottom of your foot pass underneath these ligaments in the whip space. Etiology: the exact cause of Morton's neuroma is not known. It is thought to develop due to increased stress and irritation on one of the plantar digital nerves. This increased stress may cause nerve to be compressed, wrapped, or stretched. Ill-fitting footwear is a well-known cause in aggravating your symptoms. Ill-fitting footwear that is too narrow or has a thin sole, that is high-heeled shoe, being overweight, foot deformities such as hallux valgus, hammer toes, inflammatory conditions that is rheumatoid arthritis, psoriatic arthritis, etc., previous foot trauma that is metatarsal fracture, knee nerve injury, weakness in the muscle within your foot or leg, tightness in the muscle up the back of your leg may cause you to load more through your forefoot. Wearing unsupportive footwear such as shoes or sandals which have a low heel. Wearing footwear with low heel, unsupportive footwear also causes Morton's neuroma. Spending long periods standing, walking, or running, especially with a sudden increase in these activities. Mechanism of injury. Osuna and Singh categorize these into four theories: the chronic trauma theory. Mechanical effects of walking cause chronic microtraumas to the intermetatarsal plantar digital nerves, which become compressed between two metatarsal heads and the metatarsophalangeal joints. And the next is entrapment theory, the compression of interdigital nerves against the anterior end of the deep transverse metatarsal ligament and plantar soft tissue structure. Inter- intermetatarsal bursitis theory. Bursitis is in the intermetatarsal region, causes compression and inflammation with subsequent fibrosis of the ischemic theory. According to this theory, common plantar digital artery exhibiting degenerative changes prior to the fibrous thickening of the nerve. These are the symptoms that can be seen in patients suffering with Morton's neuroma. Persistent burning or sharp pain in the ball of the foot may radiate into the toes, especially during weight bearing activities like running or walking. Night pain is rare. Patients frequently describe the sensation of having a pebble or marble under their forefoot as they walk. Pain is typically between the base of the third and the fourth toes, but it can occur between the second and the third toes as well. There may be numbness or an unpleasant tingling in the toes. Printers may feel pain as they push off from the starting block. Problems with shoe wear are common. High heeled shoes, which put the foot in similar position to the sprinter's push off, can aggravate the condition. Tight, narrow shoes also aggravate this condition by compressing the toe bones and pinching the nerve. Clinical examination. As a clinician, how are we going to diagnose diagnose clinical Morton's neuroma? There is a specific examination that can be performed. It's called Mulder's click. The patient is positioned in long sitting position in a couch, while the medial and lateral aspects of the forefoot of the patient are grasped by the clinician examiner using one hand. The examiner then proceeds to squeeze the medial and lateral parts of the foot, earlier grasped with a hand, while the tender area is palpated with the other hand. The positive test is indicated by aggravation of the pain. Diagnostic procedures include X ray, MRI, and ultrasound. This image, you can see that the Morton's neuroma is seen between the third and the fourth toe. The Morton neuroma bulges superiorly as well as inferiorly, and it gives the appearance of figure of 8 or the dumbbell shape. Coming to physiotherapy management, as a physiotherapist, what can a physiotherapist do in this situation? Patient education. The patient should be educated regarding these following things. This include avoiding narrow and high heel shoes, staying compliant with footwear prescription, and activity modification. Footwear modifications include sufficient long shoes, wide toe box, low heel, thick external sole which may not be excessively flexible, metatarsal padding, a rocker bottom sole may be helpful. Sufficiently long shoes, orthotics to displace pressure sites to provide pain relief. The most common orthotic provided initially is metatarsal bar. It aims to spread the heads of the metatarsals to relieve pressure and improve symptoms. Manipulation and mobilization. According to Cashley and Cochrane, manipulation and mobilization of the other foot and ankle joint can decrease foot pain in patients diagnosed with plantar digital neuralgia. The authors recommend performing joint manipulation once a week for 4 weeks, followed by 2 more visits at 14 days interval. Exercises: half kneeling soleus stretch, pair position big toe stretch, seated ankle inversion with band, side step with band around the forefoot, pogos alternating. Surgical interventions include decompression surgery, is when the surgeon releases or cuts surrounding tissue, take pressure off the toes. Nerve removal is a procedure of last resort because the surgeon will remove both the nerve and the neuroma.